Okay, congenital adrenal hyperplasia. It's what it sounds like. They're born with overgrowth of the adrenal gland. So the pathology is because of the overgrowth of the adrenal gland, the production of mineralocorticoid and glucocorticoid is blocked. This reduces overall cortisol levels. Then ACTH production increases to try to stimulate adrenal gland production, and then hyperplasia of the adrenal glands gets worse or occurs, and it leads to excessive androgen production. If you remember, our androgens are like our sex hormones. So when we have congenital adrenal hyperplasia, the cues that we see, the very first cues that we might see in a newborn is vomiting, lethargic, hypotonia, and poor feeding. Males tend to have some salt wasting, and they call it salt wasting disease. Um, Only in males, the females are not affected as much. So the males will have a slightly enlarged penis because they are receiving excessive androgen. They're going to have a hyperpigmented scrotum, and they're likely to go through precocious puberty at 2 to 3 years old if it's untreated. Likely they wouldn't get that far because the salt wasting can kill them. So the females, they develop, because of the androgen production, they develop male secondary sex characteristics, which is what we would call ambiguous genitalia. So they end up with an enlarged clitoris that can appear to be a penis, rugated labia, which means it's got the folds in it, kind of like a scrotal sac, so it resembles a scrotum. And their labial folds are frequently fused, so it's difficult to visualize the vaginal opening. So if you look at this picture, which it's very graphic, but that child at birth might be misconstrued, or they might not even know whether it's a female or a male. And if they did hormonal lab tests, they still wouldn't get a very good answer. So these types of issues kind of are in the forefront of the national news, worldwide news, basically, when we talk about gender and sexuality. Obviously, this has nothing to do with sexuality whatsoever. Our secondary sex characteristics don't have anything to do with who we choose to have sex with. Our gender has nothing to do with it either, but our gender can be ambiguous. It can be visually specific, like maybe a male with a penis and a scrotum, and visually you can see that, but internally they might have ovaries, and their DNA might have chromosomal anomalies that are more female than male. And the same thing can happen on the female side. You can give birth to a female that, by all accounts, looks like they have female organs. So the assumption is made that they are completely female. But they might have multiple genetic markers and chromosomal anomalies that are more male, and they might have internal anomalies that are male as well. So gender is not clearly defined, and it's not clearly defined at birth. Um, so I just want you to think about that. These children, male and female, also are born with fluid and electrolyte imbalances. They will have hyponatremia, hyperkalemia, and hypoglycemia. So low sugar, low salt, high potassium. And you can imagine the problems that this causes. We also see them be hypotensive the majority of the time. Okay, these are the diagnostics or laboratory workups that we do. We're going to do newborn metabolic screening, and hopefully that metabolic screening shows that there is something not correct, and it would lead us to do some more in-depth testing. We're going to do x-rays, and they're going to show advanced bone age and epiphyseal plate closures. So like how this said that the child by age 2 to 3 would be developing precocious puberty, this is where it starts kind of. So their bones are older than they should be. And then they stop growing. They have low glucose, low sodium, and elevated potassium. So the management of children with congenital adrenal hyperplasia is to use hydrocortisone orally. We had a little patient, well, I mean, I've had plenty of them. I see more males than females. And families are always super concerned and super confused because with the males, like I said, there's not often an obvious physical anomaly other than larger than normal sex organs. So, and that parents don't necessarily think that's always a horrible thing. So, once they find out their kid has adrenal hyperplasia, it's usually because they brought them in because they are hypotensive and very difficult to arouse. Like they're so bradycardic and they're so lethargic, and their glucose can't be maintained, and neither can their temperature. And so within the first couple of weeks of life, they're being brought to the emergency room multiple times because of low temperatures. And then they do finally glucose checks and they find out they're super low. And then they bring them in for further testing. So we give them little bits of hydrocortisone orally. We can give them Florinef. We might do sodium supplementation depending on what the levels are. But sometimes we can get away with just giving them D5NS. And then some of the management is also surgical correction of the genitalia. For the females, or for what looks externally to be a female. I don't necessarily conscribe to this as a quick fix because, like I said, they might not know until much later in life that that child is maybe more male than female. And I think it should be the person's ultimate choice, what they want done with their own genitalia. I can understand when the parents want it to be resolved so that they can have less stress. I understand that. But yeah, so that's the management. And then these are some of the interventions that we do for congenital adrenal hyperplasia. We want the family to get a medic alert bracelet because we should know if this child is hospitalized that they were born with congenital adrenal hyperplasia so that we can monitor their electrolytes effectively, and so that we can just give them hydrocortisone if they need it, because that might be all they need. At the bedside, we're going to use genderless terms for the baby. We're just going to say baby. We're not going to say he, she. We are going to say baby. And we're not going to call it a penis or a vagina or labia. We're going to most of the time refrain from using any terminology for the sex organs other than just saying the sex organs or the pubic region or things like that. And the reason why we do that is so that the family doesn't feel like we are assigning a gender to their child, and so that they can also come to terms with what their child needs, and kind of just get used to dealing with the disease process itself rather than worrying so much about everybody else's opinion on the genitalia. We educate them regarding the meds, and some of the things we have to educate about is that because the child takes oral hydrocortisone, if they're sick and vomiting, we need it to be IM. So we're going to send them home with oral and IM doses of hydrocortisone, and we're going to instruct them on how to use both and when to use them. They need to know that they might have to use what's considered a stress dose for illness, stress, or surgery. So basically, it's like a little bit extra for those periods of high cortisol use. We monitor for acute adrenal crisis, and the cues that we would see in an acute adrenal crisis are vomiting, dehydration, hyponatremia, hyperkalemia, hypotension, tachycardia, and shock, which is basically kind of the same things that this baby had when they were born. And then we want to treat the crisis with IV steroids, fluid resuscitation, like I said, using D5NS. And the complication is usually, these are the only ones. If they give too much hydrocortisone, it can cause hypertension, growth impairment, and acne. Other than that, they're usually pretty good. They don't have a lot of issues later on, and the females might need to have surgery, like I said, for their genitalia.